Hi, I am Dr. Dilip Kumar. Welcome to Medica CardioTalks episode 4. Today we will hear about ECMO, its role in COVID pandemic, and its role in advanced cardiopulmonary dysfunction. We'll also hear about some interesting and important studies which are presented at ESC 2020. So over to a team which has done maximum number of ECMO in COVID patients with exceptional results. Over to Dr. Kumar Sarkar.
Hello friends, I hope you're all keeping well. Now, of the different forms of treatment we have done in the history of medicine, which probably goes back to about 6,000 or 7,000 years, it is only within the last 50 to 55 years that we had some kind of mastery of the technique to maintain blood flow, oxygen content outside of the body when we have problem with our heart or lungs or both. So the term ECMO sounds like a complex abbreviation. Actually, it's very simple. What it means is extracorporeal, which means outside of the body, membrane oxygenation. So it takes over the function of the lungs and the heart, if required, outside of our body. And this kind of a technology has been a great help as far as heart surgery is concerned. And from heart surgery, over the last few years, it has been applied in the treatment of critically sick patients. In the last few weeks, we've heard a lot of ECMO because of the COVID pandemic. Because let us remember that in the COVID pandemic, the organ that takes the full blast of the disease is the lungs. And for those people who have been very sick with absolutely severely damaged lungs, this has been a life-saving intervention. So I think I have two of my friends with me, and perhaps not just my juniors, my colleagues, but perhaps the two hardest working people I've seen for many, many years to come. Dr. Dipanjan Chatterjee and Dr. Orphan Chakraborty. And I think Dipanjan will share with us in a few minutes, in a nutshell, that what is the overall scope of ECMO. That what are the cases? It is not as if we've only used ECMO for the time of COVID. In the non-COVID situation, what has been the use of ECMO? And have we really felt that we've been able to benefit very severely sick people with this kind of treatment?
Thank you, Dr. Sarkar. ECMO has been used for the two purposes, mainly to support the patients with an acutely failing heart or an acutely failing lungs. So these are the two conditions where ECMO's use has been very prominent. Suppose a patient with an acute myocardial infarct, his cardiac output goes down very fast. In these patients, the tissue oxygenation or the tissue perfusion gets hampered. And in them, if we can institute ECMO as a cardiac support, there we can maintain the tissue perfusion till the time the myocardium improves its function and it can take its own, the heart can function to perfuse the tissues. Till that time, ECMO can be used. The other situation is in acute pneumonia or in various toxicities where the lung function goes down very fast, the oxygenation function and the decarboxylation function of the lungs does not occur, even with a very high ventilatory support, where we are this ventilatory support is itself detrimental to the patient. We can institute ECMO, it's a respiratory support or a veno-venous ECMO there to improve the oxygenation and decarboxylate this blood so that the lungs can get a rest and its function will improve gradually. And at a time when the lung function improves to a significant extent, we can remove the ECMO support. So this ECMO has been in use since the 70s, but its use has been more in the last 2 decades, mainly after the swine flu epidemic came in the 2009-2010. There the real use of this ECMO was seen. The benefit was palpable in the patients who were supported with ECMO and those patients who were not supported with ECMO. That there was marked difference in the mortality of these patients. So we have been using ECMO for a variety of patients like these, not only in COVID but also in the pre-COVID era, where we have done almost 100 patients of ECMO. Around 40% will be for the cardiac support and the rest 60% will be for the respiratory support. And the mortality benefit is starting.
Dipanjan, thanks. Just to make a small point, which is, as Dipanjan gave us an overview, let us be very simple and clear about the fact that here we are talking about extremely sick patients. When ventilation, inotropic support is, even with the highest form of ventilation and inotropic support, the doctors feel that we have come to the end of the road. We have nothing to offer. Somebody who probably does not even have a life expectancy of 48 hours. Those are the type of people who are supported. And when you are able to send a fair percentage of them home from the brink of ensuing disaster, it really means a lot to them, to their relatives, and to the doctors like yourselves who've been looking after them. Now, as Dipanjan said, that ECMO has been in discussion, has been prominence in the COVID era. And once again, when we were faced with the toughest of cases, that people who were not doing well, neither on high flow oxygen nor on ventilation, this was almost the last recourse. So to give us a kind of bird's eye view of our overall experience with ECMO and COVID, Dr. Artun Chakraborty.
Thank you, sir. So, the ultimate truth which has been prevailed in last 6 months is regarding COVID is whatever the 100 drugs were trying to prove is efficacy in COVID, the only one modality is working nicely, that is oxygen. So what Dr. Sarkar told that some amount of oxygen in the form of nasal cannula, some form of high flow cannula, some form of BiPAP, some form of ventilation, where some amount of lung tissue is still there to work. But when your lung is not working, their place, how you supply the oxygen to the tissues. So here comes the role of ECMO. When your lungs become a brick from a balloon, at that point of time, there is no point in hammering the lungs with recurrent ventilation and recurrent pressures. So what we do then, we take them on ECMO. From our experience from 2014 of almost around 100 cases per year, at least 20 cases per year, where the 60% were on the acute respiratory failure, like H1N1 patients, like in severe bacterial pneumonias, like in pregnancy, sometimes this meconium, this aspiration syndrome, and babies and amniotic fluid embolisms, near drowning. These are the patients where they have been immensely benefited from ECMO as a respiratory support, where the lungs has become stiff and we have rested the lung on ECMO for a 2 to 3 weeks time, where lungs get time to recover. from our past experience, this extrapolation of our ECMO experience has given a good result and continue to be giving a support to the end stage, the severe COVID pneumonias, where a myth is going on, nothing works. Neither any drugs are working, neither steroids are working. Every path is ending at the level of moderate COVID. So in severe COVID, what we are getting a tired lungs, and we have to support them. How do we support? We do take out its work, its oxygenation, its decarboxylation outside the body on ECMO, and we rested the lung. We rested the lung till it recovers, and there is a possibility of lung not recovering, because a lot of earlier reports and current reports are coming that patients are in a process of accelerated fibrosis. Lungs is getting replaced by non-lung tissues like fibrous tissues, and those non-working lung tissues are not generating adequate oxygen if they are out of pneumonia. Then what to do? Then ECMO acts as a bridge to some transplant, because your lungs has to be transplanted to prevent that imminent death on this organ support. So ECMO is working as a bridge to recovery, and those who are not recovering, we can offer them a definitive treatment like lung transplant or pulmonary transplant, bilateral lung transplant in such cases where this fibrosis has already set in. So it has become a life support system, which is very much a continuation of our earlier work in Medica for the last 5 years. And we have successfully applied this technology to, in case of severe COVID, where only the oxygen delivery to the tissues matters, and it is working nicely. Thank you.
Orpon, thanks a lot. Not only are they very hardworking, but they're very modest as well. And we are so glad that from our city, from our hospital, we have been able to produce what remains one of the singular, largest and seminal experiences of ECMO in our country, and probably one of the largest bodies of experience of this region. So once this kind of tsunami is over, I think our next responsibility will be proper scientific data collection and publishing of what has gone on over the last few years. Now, I think those of you who would be keen to know more about this treatment, and should you ever need any help to consider ECMO in anybody who is in desperate need of this treatment, feel free to contact the hospital. Feel free to contact us. It doesn't matter to us what time of day, night, early morning, late evening it is. We are always there, because this is a job, this is a work where every minute counts. Thank you. Be well, be safe.
I'm joined today by Dr. Somya Patru. He is my colleague and a senior interventional cardiologist. So, Dr. Somya, recently 2020, a few days back it was finished, and we saw a lot of important trials, data were presented, and many landmark trial and head-breaking trials were presented. So if you have to rate top 4 trials from ESU 2020, so what would be your choice and top 4 studies for you?
Good evening, sir. Actually, ESC 2020, it was a very important and successful virtual conference already held, and more than 1 lakh delegates they have enrolled for this conference, and we came across very new data and ideas, and it emerged from this conference, and that could be game changer for the management of cardiac patient in near future. And I think, sir, these 4 trials which will be practice changer for our purpose, like Emperor Reduce trial, this popular TAVI trial, and Explore ACM, this new drug came which can be used in the management of hypertrophic cardiomyopathy, and Parallax trial. These are the 4 game changer in my point of view, sir.
Yeah, great choice, Dr. Somya. So let tell us something about the summary of Emperor Reduce trial.
This Emperor reduced trial, sir, it has shown that the SGLT inhibitor empagliflozin is given one of the management modalities in the management of chronic heart failure with heart failure reduced ejection fraction. Those who have a ejection fraction of less than 40%, and the mean ejection fraction here was to around 27%, and they found that in addition of previous medication like ARNI therapy, ACE inhibitors or ARBs, beta blocker, and aldosterone antagonist, this SGLT inhibitor empagliflozin shown to have a mortality benefit, reduction in the readmission for heart failure, and improve the clinical parameters also in this NYHA class. So it is a great choice. And previously, sir, there is the DAFA heart failure trial also found this SGLT molecule, SGLT2 inhibitor molecules have a class effects and should be used in patients those who have diabetes or non-diabetes in the management of chronic heart failure in addition to the present management.
Yeah, correct. And a lot of positivity was shown in this particular trial, as it also reduced the renal decline.
Yes.
So, what is your view on that?
Yes, sir. This is good observation by you, sir. There is another trial in this conference presented, the DEPA CKD trial, and they also found that even in the patient with CKD stage 4 and all, this molecule can be given, and it has a great benefits in the management of heart failure with reduced ejection fraction.
So, SGLT2 looks very promising, and probably it has a place and which can't be ignored, and it has to be given to all patients, those who have ejection fraction of less than 40%. So moving on to the next study of choice of Dr. Somyo, I think you rightly pointed out in HCM we have got some molecule which is acting at the molecular level rather. Yes. So what is your idea on explore HCM trial? And
actually, sir, this is very new molecule. It is myosin inhibitors, and it has a negative inotropic effects on the cardiac muscle, and that is why it has shown it improves the LVOT gradients. Means LVOT gradient will be decreased in obstructive hypertrophic cardiomyopathy, and there is increase in the 6-minute walking distance that will also be increased after giving this mevacamten. This is newer molecule, though it is not available in India. I think we are expecting in the near future, so that even in the in patient with obstructive hypertrophic cardiomyopathy, previously you are also doing a lot of patients with alcoholic septal ablation and all, and in addition, if we use this molecule and the patient get benefit in this type of disorder, and it is commonly found in our patient, so I think it will be
symptomatic patients who were having gradient of LVOT gradient more than 50. They found to be having responded significantly better with this drug, which reduced the NYHA class and also increases exercise capacity.
Yes.
So it has got a role. So, but is there any concern while giving this mevacamten? Is there any safety, any caution while you prescribe?
As it is a negative inotropic effect, so it can reduce the heart failure maybe in the long term. Though this study is not very long term because they have studied up to 12 months and all. Maybe we have to be cautious when we are using this.
It can precipitate sometimes hypertension and heart failure, just like beta blockers. But I think we have to be a little more careful, even more than when we prescribe beta blockers. So extremely important study. And then we have a very disappointing result with we long expected ARNI in HFpEF. So Parallax trial, could you highlight, give us some highlights of Parallax trial, what message we found?
Yes, sir. It is nice observation by you that heart failure in preserved ejection fraction, they have enrolled the patient, those who are having the ejection fraction of more than 40%, and blood pressure is not less than 110 or not more than 170. These kind of patients they have enrolled, and they found that this molecule, ARNI molecule, though it is successful in the management of heart failure reduced ejection fraction, but they found in heart heart failure with preserved ejection fraction, there is no clinical benefit except this biochemical parameter. This NT-proBNP was reduced significantly, but there is no clinical benefit in the form of NOHA class or the physical activities. It was not improved, but there is marginally improvement in the reduced hospitalization rate after using this molecule, and the renal function also preserved when they use this RNA therapy. But clinically, it has
So it is essentially a negative trial.
yes.
So the study didn't met the primary endpoints, and although there was a trend of low pro-BNP levels, but there was no benefit in clinical outcome. So it's again a disappointing study, and it's proving again and again that we are helpless in treating patients with HFpEF. So we have made a long headway in treating heart failure with reduced ejection fraction, but in HFpEF we are preserved.
Yes.
So final one trial we'll discuss is lesser is better. What we are moving. What is the trend in antiplatelets, anticoagulation, and that is again emphasized in TAVI trial, popular TAVI trial. So your crisp and idea about popular TAVI trial.
Yes, sir. This is also another good trial presented in this conference, and in our center, sir, under your guidance, we are planning to establish a TAVI center in Medica, and definitely we are very much concerned the medication which has to be given after the patient underwent this TAVI transcatheter aortic valve implantation, and it is also in low risk patient. It is now coming in the guideline, and so we may suggest the patient who are having significant aortic stenosis to have this kind of therapy under our cardiology department under your guidance. So they found in this popular TAVI trial that even say after surgical therapy they need 1 month of anticoagulation, then they will give dual antiplatelet therapy for long. But in popular TAVI trial, that after this transcatheter valve implantation, only single antiplatelet with ecospin is sufficient to prevent valve thrombosis, to prevent any cardiac complication after TAVI, and the bleeding risk, especially the bleeding risk, was very less after if patient is on even with aspirin rather than giving dual antiplatelet. Those patients who doesn't need actually this no oral anticoagulants. So I think this is a very good trial that and we can suggest to our patient that if you undergo with transcatheter aortic valve implantation, you need single antiplatelet therapy, and you will be all right on the next day or after 24 to 40.
Thank you, Dr. Sharma. So we got idea about the top 4 trials which we felt we need to discuss with all of you, and 1 or 2 more trials were there where we have not got any concrete evidence like colchicine. So it's again which has shown some benefit, but there are concerns about non-cardiovascular mortality. So thank you so much everyone for watching and hearing us, and see you next month again. Thank you so much.